Dear colleagues, dear participants of RENA Nexus exclusive roundtable on the treatment of nephrotic syndrome in children. It's my great pleasure to welcome you all to today's session. We are honored to be joined by the most distinguished experts in the field, the Professor Marina Vivarelli and Professor Jürgen Floege, renowned for their pivotal contributions to the development of international treatment guidelines for pediatric nephrotic syndrome. Professor Lutz and Professor Eugene Chan and Professor Bagdasarova, world-class clinicians and researchers whose work continues to shape the future of pediatric nephrology. I am deeply grateful to each of you for paying time in your demanding schedules to participate in this important event. Your presence here today is a testament to the shared commitment we all have to advancing care for children affected with nephrotic syndrome. The theme of our roundtable is simple yet powerful. We do not retell the guidelines. We present them through the voices of their creators. To begin our session, I am pleased to invite Professor Jürgen Floege to deliver the welcome address. It's my honor to introduce Professor Jürgen Floege, a globally recognized nephrologist whose groundbreaking research has shaped our understanding of glomerular diseases. He is one of the key contributors to the development of the current treatment guidelines for the nephrotic syndrome in children. Please, Jürgen.
Thank you, Dimitri, and it's a great pleasure talking to you. So first, I think it's important to stress I'm not a pediatrician. I'm an adult nephrologist, and I have been coordinating the KDIGO guideline for quite a few years now, and I still have not confessed to my wife that I'm possibly married to KDIGO. So if you ever want to work hard, coordinate a guideline, I can tell you it's a lot of work, but I've made great friends, and it's a wonderful work. And as you all know, we are in very exciting times when it comes to glomerular disease. We see two fundamental changes. First of all, in many instances, we now understand the pathogenesis, and we get away from the largely pathology-driven terminology. So in a few years, we may no longer talk about minimal change disease. We may talk about an autoimmune podocytopathy or a podocytopathy due to mutations of XYZ. In IgA, the other thing is really visible today. In IgA nephropathy, we've seen decades where we discussed, should we give steroids or should we not? And that is all we have discussed forever. And all of a sudden, we see an explosion of clinical trials. We see an explosion of new drugs. And yes, this is great news. And there are safe new drugs. And we see the problems, and we just start to realize the problems. If a new drug comes to the market for IgA nephropathy that will cost you $500,000 per year, it's a disaster. It is something where even wealthier Western countries have problems in placing these therapies because they are so expensive. So in a way, pediatric nephrology is still in the good times when it comes to therapy, because you talk about steroids, they're dirt cheap, everybody has them. But it's very foreseeable that these changes that we see in adult nephrology will reach pediatric nephrology soon, and the first companies are working on pediatric patients, starting with IgA nephropathy, but likely others will come. So it's a very timely discussion that we will have today on how to treat nephrotic syndrome in children and with what and how safe is it. And I think it's a great thing that me, an adult nephrologist, and pediatric nephrologist sit together in one session, because It is so important that you know what happens to your children when the children are 20 years old, and I've seen 30-year-old children still being treated by pediatricians. It is so important that we talk to each other and we get a feel how safe are your therapies in the very long term. And I'm very pleased that the first lecture is from Marina Vivarelli. We just had a wonderful meeting on B-cell therapies in glomerular disease, and Marina's contributions really were enlightening, that you see totally different complications in children than we see in adults. I've learned a lot at that conference. So it's a great pleasure to hand over to Marina, who is the coordinator of this part of the guidelines. And thank you, Marina, for doing this.
Thank you kindly, Professor Floege, for your thoughtful and inspiring opening remarks. And we have already one question. May I kindly ask you, what were the most challenging aspects of harmonizing international perspectives with developing the treatment guidelines for pediatric nephrotic syndrome?
It's a fundamental theme. In pediatric nephrotic syndrome, it is not so difficult because, as I said, the discussion is still largely centered around steroids. They are available everywhere. But even when it comes to MMF is kind of expensive. So the big challenge in KDIGO is always that these are global guidelines. And that's important to stress. These guidelines must be applicable in India, must be applicable in Africa and wherever. So very clearly that is a challenge. But in the case of nephrotic syndrome in children, it was relatively easy. We had much worse instances in IgA nephropathy.
Thank you so much, Professor Floege. And your leadership in shaping the guidelines and your continued dedication to advancing pediatric nephrology are truly appreciated. Thank you once more. And now we move to the core of today's session, the presentation of updated treatment guidelines for nephrotic syndrome in children. It's a privilege to welcome Professor Marina Vivarelli, whose leadership and expertise have been instrumental in shaping these recommendations. Please welcome Marina Vivarelli as a leading expert in pediatric nephrology, whose clinical and academic work has been defining evidence-based approaches for treatment of nephrotic syndrome. Marina, you're welcome.
Thank you so much, Dimitri. Thank you to Jürgen for their very nice introduction and for setting the stage to my talk. So I'm going to share my screen now and we're going to get started. I hope you can see my screen. Okay, so I'm going to talk to you about what's new in childhood nephrotic syndrome, going to the current IPNA and KDIGO guidelines and also to what may lay beyond, because we know that the guidelines are always slightly behind the most recent and exciting and innovative discoveries that we make, because they need to be verified. To connect with what Jürgen Floege was mentioning, in the specific case of guidelines for childhood nephrotic syndrome, we were very lucky to have the IPNA guidelines, both for steroid sensitive and for steroid resistant nephrotic syndrome, being created more or less in parallel with the KDIGO chapter on nephrotic syndrome in childhood. And this really allowed us to coordinate and to bring the field forward in a parallel fashion, coordinating our efforts to make sure that everything was uniform, because it's very important to have a common ground and common definitions and common guidance to avoid confusion. So let's get started, and I'll be glad to take questions at the end. I'm a pediatric nephrologist and also a clinical trialist working, and also a basic scientist in reality, working at Bambino Gesù Children's Hospital in Rome. Okay, so the first description of nephrotic syndrome is probably found in this manuscript that describes the 51st disease of children with swelling of their entire body. So nephrotic syndrome has been around for a long time, and physicians have always recognized it in children by recognizing the fact that they had edema, so swelling of their entire body. And it took a while to figure out that that edema was secondary to the massive loss of protein in the urine. So we now know that nephrotic syndrome of children is the most frequent glomerular disease in childhood. Here we have both the incidence depending on the different ethnicities for the whole disease, so childhood nephrotic syndrome. And we see that it is on the left-hand panel most frequent in Asians, Southeast Asians, and people of Arab ancestry. It is relatively less frequent in Europeans. In terms of the separation between steroid resistant and steroid sensitive, once again, there are differences based on the ethnicity of the patients. And more specifically, it tends to be more frequent in patients of Black or Indian race and Southeast Asian or Asian ancestry, and less in Europeans, regarding the more difficult forms of the disease, which are, as we well know, the steroid-resistant forms, which are also the forms that may lead to loss of kidney function, whereas the steroid-sensitive forms are forms that respond to conventional immunosuppression, and as long as a child maintains steroid sensitivity and is therefore responsive to glucocorticoids, kidney function will never be impaired, if not momentarily, during the acute phase of the relapse. So here's some basic concepts that are important to keep in mind. Regarding these diseases, we know that the vast majority, fortunately, are steroid sensitive. And as I was saying, that as long as a patient is steroid sensitive, he will not or she will not progress to end-stage kidney disease. So this is an important basic concept just to get started when you're considering a child that you may be taking into your care. If he or she responds to glucocorticoids, it's a completely different ballpark from if he or she does not. The other thing is that even steroid-sensitive forms, however, may have a rather significant burden of disease because this is a chronic disease that classically has its onset in smaller children between the ages of 3 and 7. And it can last for decades with relapses that can be more or less frequent depending on the patient. After puberty, between 70 and 90% of patients will have a spontaneous and prolonged remission of the disease, so a long-term remission, but a certain percentage, between 10 to 30%, and usually it's the more severe forms that tend to do this, will continue to show relapses even as young adults. And of course, so if we think of a disease that can last decades, even though it doesn't lead to end-stage kidney disease or it doesn't impair kidney function, you realize very well that it does have an important impact on the quality of life, especially due to the fact that we need to use different forms of immunosuppression in order to maintain the child in remission and in order to prevent relapses. And so the therapy that we choose to use needs to take into account a risk-benefit profile that needs to be positive in order to maintain not only as little instances of relapse as possible, but also to minimize the toxicity that can derive from giving prolonged immunosuppression for years and sometimes for decades to our patients. So this is the definition of nephrotic syndrome. This is the definition that you will find when you see both icons, both the IPNA and the KDIGO icon. It's because the two guidelines are identical in this specific instance. And so the definition of nephrotic syndrome is the presence of a proteinuria, which is a very intense proteinuria, so a defined nephrotic range proteinuria. And here you see the numbers that it needs to reach to be defined nephrotic range, together together with either, if you can have a blood chemistry, the presence of hypoalbuminemia, which with a serum albumin below 30 grams per liter, or when serum albumin levels are not available, the presence, as we were mentioning right at the beginning, of edema. So the swelling of the body, the edema is visible at the level of the puffy eyes, at the ankles, at the genitals, and we can have pericardial and pleural effusion. So even visiting the patient, you will be able to observe these abnormalities. This combination of instances is defined as nephrotic syndrome. The other important thing that was made clear in the guidelines is that due to the fact that in children it's very difficult to collect urine, we don't expect a 24-hour collection, but rather it is sufficient to have a single sample, optimally the first morning sample, and you can then measure protein, creatinine, and therefore the protein-creatinine ratio in this sample collected in the first morning. And this is more than enough to perform the diagnosis of nephrotic syndrome. Subsequently, you continue to monitor by using a urine dipstick, but it is advisable in the first presentation to have at least once a urinalysis measured in a laboratory, whereas subsequently the urine dipstick is more than enough. Oh, and the correspondence of the nephrotic range is by dipstick to have at least 3+ or 4+. So what is happening in the kidney to determine this intense proteinuria? So we know that the formation of urine starts in the glomeruli, where there's a glomerular filtration barrier, which is in close contact to microcapillaries that contain our blood. And this blood filters through the glomerular filtration barrier into the urinary space, eliminating within the urinary space all the substances that need to be eliminated because they're detrimental, they're not good for you. However, this tightly regulated structure does not physiologically, when it works correctly, allow the passage, for example, of albumin, the main protein of our blood, because these are components such as also immunoglobulins, hormones, etc., that we want to remain within the blood and not to go out into the urinary space. So you see that the glomerular filtration barrier is made of internally blood vessel, which is full of little holes called fenestrae. So it's a highly specialized particular type of endothelium called fenestrated endothelium. The glomerular basement membrane, which is made of different proteins, such as the collagen proteins, nephrin and potosin, and then the proteins that are composed within the pedicels of the podocyte, which is the highly specialized cell that forms these interdigitations, which create like a sieve, so a real filter, allowing the passage only of the substances that we want to pass and not of the others. And this is what is present when everything works perfectly, and you see these beautiful images of a perfectly functional podocyte with pedicels. So in nephrotic syndrome, the whole structure is completely altered. And as you see, these spaces are completely lost. And so the sieve has holes that are much larger than what they would be physiologically. And this allows the passage of red blood cells and of large amounts of protein into the urinary space, leading to proteinuria. So what happens when we have this? We will have a child that presents with puffy eyes. This will be the face of a child with an onset of nephrotic syndrome. So when we see this, something that we have to educate our pediatricians, our basic care, primary care physicians to do is to always, in the office with the child, perform a urinary albustick to check for proteinuria. So, not think automatically only about allergies, but also consider this possibility. This is a very simple but very important first step. So how do we form a diagnosis of steroid-sensitive nephrotic syndrome, and what should we do when we suspect this picture? So in addition to the spot urine that can be done on the first morning void and to a urinalysis, in the blood, measuring serum albumin is useful, measuring blood lipids, measuring a complete blood count where we will see high platelets. We know that we will also see high levels of cholesterol and triglycerides. The kidney function is good to check, even though in most cases it is actually normal. And then there can be microhematuria in the urinalysis in about roughly 25% of patients with a classic idiopathic form of nephrotic syndrome. But if there's macroscopic hematuria, so the urine is visibly red, this should probably make us think of a differential diagnosis with a non-idiopathic form. And we should check things like complement C3, C4, anti-nuclear antibodies, anti-streptococcal antibodies. We know that acute post-infectious glomerulonephritis is very frequent in children, and also, especially if there's an impairment in kidney function, ANCA antibodies. We also should consider, because the vast majority of these children will then receive glucocorticoids, prednisone or prednisolone, to check the titers of their total immunoglobulins and specific, for example, varicella and measles, mumps, and rubella, specific IgG, to recognize non-immunized children, because this is obviously a risk factor, considering that then they're going to have long periods of immunosuppression, and we're going to need to take care of them optimally and try to protect them, trying to immunize them as much as possible between periods of receiving glucocorticoids. So this is quite a complicated graph taken from the IPNA guideline, but the most important concept is, to first of all think if you have a very small child, so a neonatal onset before the age of 3 months, or you have extrarenal features, so a syndromic child, or you have a family history of nephrotic syndrome, you should probably start thinking about performing genetic testing about a genetic form. If you have atypical features, such as macroscopic hematuria, low C3, an AKI, which is not related to the edematous state, so to the hypovolemia, sustained hypertension, or other systemic symptoms such as rash arthritis, then you should probably think about performing a kidney biopsy and trying to rule out other forms of glomerulonephritis. But in the vast majority of cases, you won't, and this is also something that you could consider if the child is older than 12. The classic child that will present you with puffy eyes, and you will perform the urinalysis or the dipstick and find nephrotic range proteinuria, will be younger than that. He or she will be between 1 and 12, but classically between 3 and 7. And in that child, what you do is that you do not perform genetic testing, you do not perform a kidney biopsy, you start standard course of prednisone, of oral glucocorticoids. And the standard course is either 4 weeks plus 4 weeks or 6 weeks plus 6 weeks. The first 4 or 6 weeks are at a so-called full dose, so 60 milligrams per square meter or 2 milligrams per kilogram with a maximum dose of 60 milligrams. And then the following 4 if you did 4 or 6 if you did 6 initially are alternate day prednisone at a dose of 40 milligrams per square meter or 1.5 milligrams per kilogram. The other thing that you need to do is that you need to take care of the edema, of the swelling. So depending on how intense it is, here there's a bit of a picture of what you need to do. So the first thing to do is sodium restriction, because that will help you to get the swelling down. If the edema is very intense, you need to restrict fluids as well. And in some cases, you will need to give albumin with or without diuretics. You need to be careful about giving diuretics without albumin. This is usually a good idea to avoid. You also have a higher risk of thrombosis and of infections due to the fact that you have the hyperdyslipidemia, and to the fact that you have hypogammaglobulinemia due to the fact that you're losing gamma globulins with the proteins that you're losing in the urine. So you're going to have to be careful about both thrombotic and infectious complications. So this is just a recap of what we've said. First of all, consider if you can suspect a monogenic disease, consider genetic testing. If you can suspect a secondary cause or an alternative diagnosis, you can consider a kidney biopsy, especially in children above the age of 12, but not limited to this. Otherwise, you start your oral prednisone, and then what do? You recheck your child at 4 weeks, because between 4 to 6 weeks, you're going to have the first super important differential diagnosis between steroid-sensitive forms and steroid-resistant forms. And the vast majority of your children at 4 weeks will be in complete remission, and therefore will be defined as steroid-sensitive. So now we're briefly going to look at these steroid-sensitive forms a little bit more in detail. The other things are the general measures, as we were mentioning, the diet, the fluid restriction if they're very edematous, and the vaccinations whenever possible. So the classification, once the child has achieved his initial remission and is defined as steroid sensitive, is going to be based on the frequency of relapses of the subsequent relapses. And in terms of this, with the most recent guidelines, both IPNA and KDIGO, the definitions have been modified to try to stimulate pediatric nephrologists and people caring for these patients to be more proactive about minimizing the relapses. So the infrequent relapse is now defined as less than 2, so 1 in the first 6 months, and less than 3, so max 2 in any subsequent 12-month period. So conversely, if you have at least 2 in the first 6 months or at least 3 in any subsequent 12-month period, you are defined as frequently relapsing, which is a patient in which you need to think about doing something beyond treating the single episode of relapse to maintain sustained remission. Steroid-dependent remain patients who either relapse during cortisone, prednisone, or within 14 days of its discontinuation. So let's look at the management. So as I was showing you before, we have a long history of disease, a long period during which we have to minimize toxicity. And we can do this in various ways using various different types of immunosuppression. But the goal is to achieve and to bring our patient towards long-term remission. So less than 1/3 of our patients will have infrequent relapses. So they will relapse max once in 6 months or max twice in a year. And in that case, you just treat the single relapses, and I'll show you now with what scheme of glucocorticoids. And you don't need to use anything else, and that's fine. But if you start having from 3 relapses up, and if you have even more, a steroid-dependent form, you're going to have to think about something more. So in some cases, you can simply give low-dose alternate day prednisone. You can try, especially in frequently relapsing patients, at least in the beginning. But the vast majority of these kids will actually need a steroid-sparing immunosuppressive agent. And there can be different types, and we'll look at those as we go along. The other important concept is that the situation is a dynamic situation. So every 3 to 6 or 6 to 12 months, you need to reevaluate the patient. And you always have to think, okay, how has this patient been doing? If the patient is doing well and he's in stable remission, you should consider trying to taper the immunosuppression, especially if that patient has not relapsed for at least a year. Otherwise, you need to instead obtain a so-called control on therapy. So the treatment of the relapses is a standard treatment. Again, the guidelines are very clear about this. You don't need to give prednisone for a long time. You need to give prednisone at 60 milligrams per square meter or 2 milligrams per kilogram, maximum 60, daily until the dipstick is trace or negative for 3 days. Once the dipstick is negative for 3 days, you pass to alternate day, and you give 4 weeks of alternate day oral prednisone or prednisolone for 40 milligrams per square meter or 1.5 milligrams per kilogram. Again, with maximum doses, which should not be above 60 for the main course of high dose, full dose, and not more than 40 for the alternate day. And we also introduced definitions in the guidelines, both IPNA and KDIGO, that were oriented towards trying to introduce the concept that the main goal of treatment is, on the one side, to minimize relapses, but also to allow a certain number, low but acceptable number of relapses, so that we don't overtreat our patients. So if we have ideally no relapses over 12 months, that means that it's sustained remission, and that if we have that, we should scale down whatever treatment that patient is receiving. Obviously, if he or she is not receiving anything, we're happy. And the other definition, however, for more severe patients is controlled on therapy. So if we achieve not a zero relapse, but an infrequent relapsing, so up to 2 a year, that is still considered acceptable on immunosuppression in the absence of significant drug-related toxicity. So we have to consider that this is a disease that will tend to relapse, as long as it doesn't relapse more than twice in a year, and that the drug-related toxicity is minimal. This is acceptable, and only after 12 months of no relapses do we consider tapering down therapy further. So we all know that glucocorticoids are the most invasive and disruptive and deeply damaging of these therapeutic options. They're wonderful because they work. They work absolutely fantastically, but they have a ton of profoundly disturbing side effects that we need to try to minimize by using them wisely and giving them when they are necessary, but then trying to get rid of them as rapidly as possible. So let's do some practical examples. If we have a little girl who's 9 years old, she had an onset of nephrotic syndrome when she was 5, and then she was fine for until she was 8. But then in the last year, she had 2 relapses in 6 months, followed after 3 months, so within the 12-month period, by a 3rd relapse. So she achieved frequently relapsing status of her steroid-sensitive nephrotic syndrome. At this point, if we think about how she's been treated, we see that her cumulative dose of prednisone, having had the relapses, is actually higher than what it would have been if she had been treated for a first relapse and then left for the following 12 months with a low dose maintenance of oral prednisone on alternate days. So this is an important concept. Alternate day, low dose oral prednisone can be, in frequently relapsing, not severe forms, a potentially very economically viable, but also acceptable therapeutic option to maintain remission. It is better than having repeated relapses if it is sufficient to prevent relapses and to make our patient infrequently relapsing. So again, we have here the different options, but we know that about 60% of our children will either have frequent relapses or be steroid dependent. We can think about alternate day prednisone as a first option, but then we will have to consider also a variety of other immunosuppressive agents to maintain sustained remission. So the selection of the steroid-sparing agent in frequently relapsing and steroid-dependent children with nephrotic syndrome is not easy, and there is not currently sufficient evidence to say that one of the agents is better than another. So it needs to be decided together with the patient or with the parents of the patient, considering also the sort of local situation, so the resources that are available. And the IPNA and the KDIGO guidelines did not feel that they could say more than putting them in alphabetical order: calcineurin inhibitors, so cyclosporin A or tacrolimus, cyclophosphamide, levamisole, mycophenolate, mofetil. And then we will also talk about rituximab. This was also taken up the most recent version of the KDIGO guidelines, which were just published, in which, again, in keeping with the IPNA guidelines, these agents were listed in alphabetical order. So we know that these different agents have positive and negative sides. They also have different cost. And none of them is perfect, but each of them can be chosen depending on the situation. Levamisole can be useful for frequently relapsing nephrotic syndrome patients. It works less well in steroid-dependent. Cyclophosphamide is toxic, but it's also the only agent that can give a long-standing remission and that has the highest level of evidence to be recommended. Calcineurin inhibitors work really well, but they have a lot of toxicity, so they tend to be considered less optimal. Except for steroid-resistant forms that we will talk about in a little bit. Mycophenolate is a very nice drug. It works really well. It can work as well as calcineurin inhibitors if given at the correct dose, but it is more expensive. And then there's the world of the anti-CD20 monoclonal antibodies. They are rather expensive, even though now generic forms are necessary, but they have a series of side effects that we need to be careful about, and they work better in older children. Whereas here we often have to deal with very young children where the effect on immune competence may be more profound. So to really define the best treatment strategy, we would really need for each patient to be able to understand the underlying physiopathology. But in reality, we know that this is an immune-mediated disease, but we don't really know why. We don't really know what the T cells and the B cells are doing to alter the structure of the podocyte. So what is the etiology of steroid-sensitive immune-mediated nephrotic syndrome? We don't know how we get to this, what happens in our immune system to determine this. So different theories have been brought forth. We know that in genetic forms, it's a different genetic alterations of different proteins components like nephrin and podosin, integral components of the podocyte, but also other types of proteins that are important. But with the immune system, things are a little bit less clear. So up here, we have less clarity. So for many, many decades, starting from an important landmark paper that was published in The Lancet in 1974 by Chalhoub, childhood nephrotic syndrome was considered a T-cell disorder. However, many of the evidences of a T-cell involvement are exactly applicable also for B-cell involvement. The sensitivity to steroids, to cyclophosphamide, the association with certain types of cancer, the spontaneous remission after measles, etc., etc. But the most compelling evidence for a B-cell involvement is the efficacy of B-cell depletion with anti-CD20 monoclonal antibodies, primarily with rituximab. So this was started and first observed in 2004 with this child. This was a child who had had nephrotic syndrome for quite a few years. And you see here in the lowest part, the relapses. He had a ton of relapses despite receiving prednisone, cyclosporin, cyclophosphamide, tacrolimus, all the agents that we've mentioned. Then he developed another disease, ITP. And for this ITP, he was treated with rituximab, a single dose. After a single dose of rituximab, his nephrologist was able to discontinue everything, and the child never relapsed again. So from this initial description, the EGMA randomized controlled trial versus placebo, demonstrating the efficacy of rituximab in patients with childhood onset, complicated, frequently relapsing, and steroid-dependent nephrotic syndrome, 10 years passed. But this really proved that rituximab was a very attractive option for these patients. And this is data from the first 40 patients that we treated in Rome. 8 of these 40 patients, most of them after having received a single dose, never relapsed. So even rituximab proved itself in a small percentage, about 20% of patients, and in other groups it's less than this, to be potentially disease modifying, so to really change the disease completely. So in our laboratory, Manuela Colucci, together with all of us, has been trying to study the B-cell compartment of children with nephrotic syndrome for many years to understand what underlying abnormalities these children have. So we know that the B-cells are created in the bone marrow. They go into the periphery as transitional B-cells, mature B-cells, and then they are activated. They do class-switched recombination, and they become first IgM memory B cells, and then once they go through class switch recombination and isotype switching, become either IgA, IgG, or IgE, switched memory B cells and short-lived plasma cells, and then they go back into the bone marrow as long-lived plasma cells, creating the immunological memory, the B cell memory that our children need to have to be protected against infections. So when you look at all the different subpopulations of B cells in children with nephrotic syndrome at onset, in relapse, and in remission, compared to age-matched healthy donors, most striking abnormality that children with nephrotic syndrome have is that both at onset and in relapse, but not in remission, they have a higher number of memory B cells. And memory B cell levels, the higher memory B cells, are also predictive of particularly severe steroid-dependent forms of nephrotic syndrome since onset. So memory B cells really seem to be, high levels of them really seem to be a trademark of a difficult form of immune-mediated nephrotic syndrome. And this was demonstrated by many other groups in other parts of the world, and also by single-cell RNA-seq more recently in this important paper published in Nature Communications a year and a half ago. So what do B cells do? B cells make antibodies. So people have been looking for antibodies in minimal change disease of adults or in childhood nephrotic syndrome models for a long time. And the anti-CD40 antibodies had been proven to be pathogenic in a mouse model. Anti-UCHL1 had been proven both in patients and in a mouse model by Georges Deschamps' group in France. And more recently, in 2022, Astrid Vine's group from Harvard published this important paper in which, both in adults with minimal change disease, in the kidney biopsies and also in the circulation, but also in a few children, they found antibodies directed against nephrin, so the key component of the glomerular filtration barrier of the pedocells of the podocyte. So this was followed by another important publication in which we also contributed last year, in which this was looked at in more detail using a different assay, a hybrid IP-ELISA assay, so looking at the circulation of patients. And once again, not in other forms of protein spilling diseases, so not in membranous, not in controls, but only in adults with minimal change disease or with primary FSGS, and particularly in children, anti-nephrin antibodies were identified, and it was also shown that in a mouse model, these antibodies taken from patients were able to create the disruption of the glomerular filtration barrier. Here you see the percentages being really very high, 35 out of 39 in children, in particular if they had not received any immunosuppression and they were active, so nephrotic, really indicating that there seemed to be a correlation between the presence of these antibodies and the activity of the disease. Now, this is something that needs to be confirmed. The assay is very tricky to perform, so I think there's still a lot of work to be done, but this really points in the direction of confirming a crucial role of B cells in these diseases. And if you look at this, the correlation between the anti-nephrin antibodies and the proteinuria, so the activity of the disease, is really very convincing. In 14 children from our center, in which we had samples both at onset and in remission, only one that was still positive here, while he was in remission, relapsed 4 days later, really indicating that there is a functional correlation. So when we think about the different B cell compartments and when we think about the drugs that we can give that have a role on modulating B cells, we see that the only drugs that actually work on memory B cells specifically are the anti-CD20 monoclonal antibodies, rituximab, ofatumumab, or obinutuzumab. So when should we use rituximab in children with steroid-sensitive forms of nephrotic syndrome? So in the guideline, it is recommended to not use them as a first-line steroid-sparing agent, but to only use them as a second line after a first line has not worked. It is to be given at this standard dose, and it seems to work better in older kids. And I'll show you a little bit more about this in a second. So you should check CD19 cell count. You should check immunoglobulin levels at baseline. You should pre-medicate. And following the rituximab infusion, you should taper off the oral prednisone or other steroid-sparing agents quickly, except in selected cases that I will discuss shortly. This important paper by Eugene Chan showed also that the repeated infusions can continue to be effective. and therefore it can be given more than once, and it should be when necessary. Even though we don't know exactly when to decide to give rituximab again, and this is still an open question, and that in children with particularly complicated and severe forms of frequently relapsing or steroid-dependent nephrotic syndrome, giving MMF post-rituximab, as was demonstrated in this randomized controlled trial again by the Japanese group, is beneficial. The reconstitution of B cells is slower, and as long as we give MMF post-rituximab, the number of relapses is significantly lower. So let's look at some challenges and future perspectives, just a couple of concepts. So the memory B cells are not only predictive of patients who will have severe steroid-dependent forms of nephrotic syndrome, but they also, post-rituximab, predict relapse. Not total B cells, but memory B cells predict relapse. Another important concept is that when we're looking at what predict relapse at baseline before giving a dose of rituximab, we see that age is very important. And the cutoff is 9.8, so we can say 10 years. And older children tend to relapse much less compared to younger children. And so this is really something to keep in mind when we're caring for our patients. The age at the time in which we use the anti-CD20 infusion is associated with the risk of relapse. The younger the child, the worse, the higher the chance of relapse. And this is in close correlation with the fact that younger kids have higher memory B cells levels at baseline, and they also reconstitute their memory B cells much faster. Therefore, they are more prone to relapsing fast. Another concept is what we're doing to the immunoglobulin levels. Since we're giving the precursors of plasma cells, that are the cells that produce immunoglobulins, during the formation of the immune competence, which happens in a child in the first 10 years of life. So what is the situation in a child with nephrotic syndrome at onset before receiving any form of immunosuppression, including glucocorticoids? So we know that when you have active nephrotic syndrome, you're losing immunoglobulins in the urine. Therefore, the levels of both total and specific IgG, for example, anti-tetanus or anti-hepatitis B, is going to be really low because you're losing them in the urine. However, if you look at the cells, the memory B cells that either have total IgG or anti-tetanus IgG or anti-hepatitis B IgG, completely normal compared to a healthy age-matched control. So the immune competence of a child with nephrotic syndrome before receiving immunosuppression is normal. What we're doing, however, when we're giving rituximab is that we are depleting memory B cells even for more than 2 years. Here we have some patients that have a follow-up of 9 years and that still have very low levels of memory B cells. Their total B cells are going to be normal, but their memory B cells are going to be low, and that's why they don't relapse. But it also means that they may have an impaired immune competence. And in parallel, we will see low immunoglobulin levels, not in all patients, but in some. And those patients can have very prolonged and protracted hypogammaglobulinemia. Some of them, very few, will also need substitutive IgIV. So we have to recognize and check total immunoglobulin levels, even in patients with nephrotic syndrome who received even a single dose of rituximab quite a few years before. And what is the main predictor of the hypogammaglobulinemia? Age. The younger children are much more likely to develop hypogammaglobulinemia post-rituximab. So in younger children, you have a higher risk of severe infection, a higher risk of sustained hypogammaglobulinemia, a faster B-cell recovery with a higher risk of relapse, and a reduced immune competence in terms of vaccines. Another important concept is that very often after giving rituximab, we do see that the total immunoglobulins are restored. However, we see that the specific, for example, anti-tetanus immunoglobulins are not restored. So you lose your vaccine competence. In these patients, however, if you revaccinate, you will see that perhaps the titers will remain low. If you look at the actual memory B cells that are specific, these can be restored. So it's very important to remember to boost our patients for the most important vaccines, for example, hepatitis B or tetanus. So when we're using rituximab, the optimal response will be obtained in older children, particularly above the age of 9 or 10. Using mycophenolate mofetil after rituximab in severe forms of steroid-dependent nephrotic syndrome will make its effect stronger. It's important to monitor IgG levels both at baseline and periodically after rituximab. And post-rituximab, once total B cells are reconstituted, don't look at memory, total B cells, you need to assess vaccination status and administer booster vaccination. Okay, now let's quickly conclude by talking about steroid-resistant nephrotic syndrome. So steroid-resistant nephrotic syndrome is that small percentage, fortunately, of very difficult patients who will not respond to glucocorticoids. So historically, we said that the response was defined as no response after 8 weeks of steroids. This is an old slide. In reality, though, if you look at the data, look at here we compare children and adults. So this scale is days, and the scale for adults is weeks. So adults really take a long time to respond to glucocorticoids, but children, the vast majority, 98% more or less, will respond in the first 28 days, so in the first 4 weeks. So when the IPA definitions and then the KDIGO definitions looked at this, they recommended to confirm remission at 4 weeks. And the vast majority of patients will be either steroid sensitive or steroid resistant at 4 weeks. However, if a patient has only partial remission at 4 weeks, then you wait between 4 and 6 weeks and you reassess. And you will have a percentage of patients who will go from partial to complete remission, and these will be called still steroid-sensitive nephrotic syndrome, but late responders. All the others, if they have not responded by 6 weeks, will be called steroid-resistant nephrotic syndrome. Why is this really important? It's really important because, as we were mentioning before, while steroid-sensitive forms may be important in terms of long-term effects on toxicity and everything, but they will never impair kidney function, steroid-resistant nephrotic syndrome can lead to end-stage kidney disease and renal transplant. Within steroid resistant, fortunately though, a vast majority will respond to a second line with a calcineurin inhibitor, and those are called multi-drug sensitive. Those will go on to have multiple relapses like the steroid sensitive forms. There will then be some forms who never respond to anything. Those are the genetic forms, which will never recur post-transplant. And then in the middle, all of the immune-mediated forms, even the forms who initially respond and then lose their capability to respond to immunosuppression, those are very difficult and severe forms because not only will they lead to end-stage kidney disease, but they also have a high risk of recurrence after transplantation. So steroid-resistant nephrotic syndrome in children is divided between immune-mediated forms and monogenic familial forms. So how can we recognize the monogenic forms? Very young children, typically congenital, but also within the first year of age, the presence of extrarenal features, and the presence of family history. And more specifically, here you see all the different extrarenal features that can really be very heterogeneous. We can have mental retardation, microcephaly, seizures, ataxia, hearing loss, ocular abnormalities such as microchoria or cataract, thrombocytopenia, ambiguous genitalia, peripheral neuropathy, nail and patella of the knee alterations, or immune deficiencies such as Schimke immunoosseous dysplasia, also with low stature. So in these cases, we should perform genetic screening. And the genetic screening results will change depending on the age of the child. In the first 3 months, the vast majority will be nephrin mutations, followed by Potosin and WT1. From 4 to 12 months, we will have about 1/3, 1/3, 1/3 WT1, Potosin, nephrin. And subsequently, Potosin will be the most frequently found mutation. And the gray, which is the other, will start to appear specifically in young adults, and the other are now known to be very often called for A5 mutations. So same types of mutations that you see in Alport syndrome that can instead give focal segmental glomerulosclerosis. So an NGS panel will really capture the vast majority of these mutations. And the other important concept is the kidney biopsy. So biopsy should not be performed routinely in these children. However, if we have older children, atypical features, those are children in which we need to think about performing a kidney biopsy. So the kidney biopsy, you see the cutoff is really 12 because until 12, the vast majority of the kids will have minimal change disease or FSGS. It's after 12 that you start having membranous and then other forms such as lupus, IgA, and C3 glomerulopathy, whatever. So at this point, it can be useful. The biopsy, when performed, will most frequently give either a minimal change disease or FSGS, and now we know that this can be a spectrum depending on the timing of the biopsy, or a diffuse mesangial glomerulosclerosis, also going towards FSGS. And then in about 20% of cases, you can have other diseases such as IgA, membranous, Alport, et cetera. So how do we manage these patients? So we know that it depends on whether they're monogenic or immune-mediated. And it's really important to distinguish because the genetic forms invariably will lead over a variable number of years transplant. The post-transplant relapse risk will be 0%, whereas the non-genetic forms will also, if not treated and not responsive to treatment, lead to transplant. About half of the cases, there will be a relapse. So this, even on the transplanted kidney. So this means that the disease continues to recur with huge consequences for the patient. The other thing is that on the native kidney, even achieving partial remission, but most importantly, complete remission, makes a humongous amount of difference in terms of years of kidney survival that we give to our patients. And this is particularly compelling for children. So what do we need to do if a patient is steroid resistant? While we are investigating by kidney biopsy and genetic screening what the causes may be, we start a CNI, a calcineurin inhibitor, and at the doses recommended in the guideline. And we do this because the vast majority of immune-mediated forms will respond. So you see here, if we think that it's immune-mediated, we do this together with an ACE or an ARB. If we really are sure that it's a monogenic form, then we don't even start and we only use an ACE or an ARB. Why is it so important to give CNI? Because well over 50%, in some cases, case histories or descriptions up to 90%, will respond to a calcineurin inhibitor, even though it can take many, many months. So in the guidelines, what it is said that we start the CNI, either cyclosporin or tacrolimus, and then we reassess. So in patients who go into complete remission, we keep the CNI for 12 to 24 months, and then we try to consider conversion to mycophenolate mofetil to maintain remission. In the patients who have partial remission, it's really quite difficult to decide. And in the patients who have no remission, we need to start thinking about second-line approaches. These are really patients that need a multidisciplinary, highly specialized approach. And in these patients, you either enroll in a clinical trial or you consider rituximab. And Professor Eugene Chen will be talking about rituximab and steroid-resistant nephrotic syndrome in a few minutes. So with this, I conclude, and this is the main bibliography. The new KDIGO guidelines just published this year, the IPNA guidelines, both the 2023 and the 2021, and a couple of reviews, in particular the last one by Boyer, if you have a child with congenital nephrotic syndrome, can be useful. Thank you very much, and I'll be glad to take your questions.
Thank you very much, Professor Vivarelli, for your clear and comprehensive presentation of the treatment guidelines. Your work provides an essential framework for clinicians worldwide, and we are grateful for your insights today. Thank you so much. And we have some questions, and may I kindly ask you to give an answer for us. Could you elaborate on the rationale behind all the recommended first-line therapies and updated guidelines, please? Now
So the guidelines that I presented are the most updated guidelines. Guidelines are always a little bit behind research, and I think there are a lot of exciting lines of evidence, both on how to treat the initial episode, on how to perhaps bring rituximab a little bit earlier in, and of different advantages and disadvantages of comparing different drugs. But the guidelines, the KDIGO 2025 and the two IPNA guidelines that I shared with you, are the most up-to-date guidelines that should be followed, and that try to take into account differences of different settings in different parts of the world.
Thank you. And with this, how do the guidelines address the balance between immunosuppressive efficacy and long-term safety in pediatric patients?
So they do this by introducing these new definitions of controlled therapy and of so-called sustained remission. And by addressing the fact that when we're treating our patients, we have to recognize the fact that it is possible that they may relapse, and that relapsing once or twice in a year is not a disaster. The important thing is that they don't relapse more than that, and that we reassess continually, thinking about not only the number of relapses, but also the burden of the toxicity of the drugs that we are using. And if the child has a normal growth chart, doesn't have an excessive BMI, doesn't have osteoporosis, has normal blood pressure, doesn't have any side effects, if he or she is achieving either 0 relapses, which is obviously optimal, but even up to 2 a year, this is still acceptable. We shouldn't give more therapy. We should think that this is good enough and take it into stride, give as little glucocorticoids as possible when there's a relapse, and just keep on going. But also, if instead the child is doing really well and has not relapsed for 12 months, perhaps thinking about scaling down. Sometimes we see patients who go on for years and years with mycophenolate mofetil or something because, they had a really difficult initial presentation. But, now it's 4 years down the line and we haven't given him or her a chance to actually show us what the disease is doing because we haven't been tapering down the drugs. So we have to really be dynamic and assess and think, consider weights of risks and benefits, and try to give as little to therapy as possible to maintain this balance of just a few relapses and very little to no toxicity.
Thank you. And Professor Vivarelli, what considerations should be clinicians keep in mind when adapting these guidelines to the resource-limited settings, for example, our country?
Well, glucocorticoids are super inexpensive. So in some patients, the alternate day oral prednisone, if it's below 0.5 milligrams per kilogram, and this is clearly stated in the guidelines, can be a great option. If they don't accrue toxicity, they have, normal bone mineral density and a good growth chart and no cataract, that can be given for even pretty prolonged periods of time. And then within the different options, you have to really, deal with what you have. Surprisingly, sometimes even in low resource settings with the generics, even giving, especially in the older kids, a single dose of rituximab, if you can then keep the patient into remission for a long, long period of time, can be a very intelligent way of acting. A calcineurin inhibitor can be a great option, trying to keep the level as low as possible and reassessing every year or two if you can actually take that drug away. Another great option, which is very inexpensive and should be made more widely available, is levamisole, a drug that works very well for frequently relapsing nephrotic syndrome and is very inexpensive, but unfortunately is not always available. And it's not an issue of price, it's just an issue of availability.
Yeah, thank you. And the last question, please. In your opinion, what are the most urgent unmet needs in clinical research related to the steroid-resistant nephrotic syndrome? This is the last part of your presentation.
So I think the most difficult thing for clinicians dealing with steroid resistant is to understand which patients will respond to immunosuppression, and therefore we need to keep on trying and keep on hitting, versus who does not have the chance to respond because he or she has a genetic form, and we should stop hitting and prepare that patient for a transplant. And in that, I think that when they will be optimized in terms of how to measure them, anti-nephrin antibodies, potentially, at least in some of these patients, could give us an answer, but there probably will be other answers, and not all of these patients have the same disease. So I think we still need to do a lot of research to try to really identify the different biomarkers of immune-mediated forms of steroid-resistant nephrotic syndrome. I think that's the most pressing one.
Thank you so much, Professor Vivarelli, for that insightful and comprehensive overview. By far, we are to follow your recommendations and hope these results will be beneficial for our children. Thank you once more, Professor Marina Vivarelli. And now we open the floor to our expert panel for comments and reflections on the guidelines and their clinician application. And I'm pleased to introduce Professor Lutz, a respected clinician and researcher in pediatric nephrology, known for his contributions for research and his commitment to improving therapeutic strategies for children with kidney diseases. We know that he was the head of a very big trial in Germany, which was dedicated to the treatment of nephrotic syndrome. There are some variants of this treatment. Professor Lutz is a famous pediatric nephrologist with decades of experience in treating complex cases of nephrotic syndrome. So you are very welcome, Professor Lutz, for your comments and short presentation, please.
Dear Dimitri, thank you very much for these kind words for introduction. First of all, I would like to thank you as giving as a host this wonderful group here that I'm very pleased and honored to be part of. And after this brilliant and comprehensive talk by Marina, I tend to say that there are no more questions open. So I see my part here perhaps to bring some new ideas into the concept of guidelines. And for that, I've tried to share my screen for you. I think what we can really all agree on is the treatment goals in initial therapy of nephrotic syndrome after manifestation. So the treatment should be effective. There should be low numbers of side effects. We should see no or even low numbers of relapses. And doing so, we will face a good prognosis of nephrotic syndrome. And as we have already heard by Marina, the classical regime for the initial treatment is really a 6 + 6 weeks regime with prednisone, or alternatively a 4-week + 4-week regime of prednisone. And this will result in a remission in nearly 80 to 90% of patients. What we have learned over the last couple of years is really that neither prolongation nor intensification of this initial therapy really changes something in the long-term course of the disease. So the question nowadays probably is more, how can we reduce glucocorticoid treatment even in the initial treatment of nephrotic syndrome? And why we should do so, we have already heard a minute ago by Marina, because due to its side effects. So what we did in Germany was a controlled, prospective, randomized, multi-center trial on the initial treatment of nephrotic syndrome in childhood with mycophenolate mofetil versus prednisone. It is important to know that all children had been brought into remission by prednisone first and were then randomized to either an MMF arm or to the control intervention. That was the standard treatment of 6 weeks prednisone plus daily + 6 week prednisones on alternate days. The mycophenolate mofetil arm was composed of another 2 weeks of alternate day prednisone to make sure that there is enough MMF exposure before cessation of prednisone, and then go on with MMF for an entire treatment period of also 12 weeks, and all patients had been followed up for the next 24 months. In the end, all patients had been followed up for 27 months. Primary endpoint was the occurrence of a treated relapse within 24 months after completion of initial treatment. Secondary endpoints comprised the course of the disease and, of course, the drug-associated toxicities. And you can see here now the primary result that basically shows that the MMF arm was non-inferior to the prednisone arms in terms of percent of relapse-free patients. So the amount of patients that relapsed was comparable after 27 months, and there was no significant difference at no time of follow-up, as you can see here by the overlapping confidence band at all times. Also, the course of the nephrotic syndrome was not different between groups. Here showed the number of frequent relapses in the MMF and also in the prednisone arms that was really comparable. In terms of side effects, we could observe that the massive reduction in steroid exposure in the initial period of treatment had a prolonged effect on certain glucocorticoid-associated side effects, such as psychological disturbances, hypertrichosis, Cushingoid appearance, and hypertension, that was also in favor for the MMF therapy after the 2-year follow-up period. So the question for the future is the results of this INTEND trial an alternative for initial treatment of nephrotic syndrome beyond the standard course of prednisone? We think it is an excellent extension for future patient-centered shared decision-making. So I will only shortly touch the topic of frequent relapsing and steroid-dependent nephrotic syndrome. The challenge here, as we have heard already, is to sustain the remission, to minimize side effects, and to have a reasonable treatment duration. And the question that we are posing ourselves in our country nowadays is, should we change the sequence of steroid-sparing alternative treatment as outlined in the current guidelines? We have learned that probably the first option in frequent relapsing nephrotic syndrome might be MMF as an alternative to steroid treatment. And in case it is unsuccessful, we might switch to a calcineurin inhibitor, and only in multi-drug resistant cases we would probably go for rituximab. But recent evidence, and I would not go into detail in that because we have already seen it, and the expert on that, which is Eugene, will talk shortly afterwards, has shown that we might reconsider rituximab as the first option in frequent relapsing or steroid-dependent nephrotic syndrome. When doing this, we should go for B-cell monitoring and consider repeated applications. And we might also think about combining rituximab and MMF to sustain remission. We have seen that already. Why should we be cautious of that decision? Yes, because rituximab is normally very well tolerated. We have heard about the risk of hypoimmunoglobulinemia, but there are some really rare, but in case they occur, serious adverse events, which concern the encephalopathy and the progressive lung fibrosis. And before I stop, I would really like to point out that it is important to bring all these concepts and ideas into real life. And the one who really did that in his situation was our host, Dimitro, who really brought the idea of rituximab treatment in children of neuropathies in real life. And I'm sure he will share his experience in a minute also with us. What we should never forget when we are dealing with nephrotic syndrome, and this is again underlining what Marina already said, it is a complicated disease. And it is important that we keep on re-evaluating our patients for what they really need. But we should always be aware of that what really makes the decision in the treating physician. And I really like this analysis by Alison McKay. You can see here that it has a really strong influence what the historical institutional preferences of the physician was. And to a lower extent, its decision-making is due to side effect profiles, drug excess, and patient preferences, but it's only a weak influence what the scientific rationale and evidence is. So for us, the really task is to keep on communicating guidelines, to keep on communicating scientific evidence, to convince all physicians on what should be done with our patients. And with that, I'm happy to take your questions, and thank you very much for your attention.
Thank you, Professor Weber, for sharing your clinical experience and reflections. Your perspective on individualized care and long-term management adds great depth to our discussion. And I also would like to thank you for this support from German Society of Nephrology and your personal support with this experience with rituximab. We will tell about it a little bit later today. And the first question is, from your clinical experience, which patient factors most influence treatment response in nephrotic syndrome?
I think there's a number of factors, and we have already heard about. So this is certainly age when nephrotic syndrome manifests. It is the time till response in initial treatment, and for the long run, it is the course of disease. And we have, on the clinical example that Marina gave, we can see that the course can change over time. So an infrequent relapser can become a frequent relapser and vice versa. So we have to consider all these aspects. It is of less importance, to my mind, what the histology is. So at least we do not biopsy patients with nephrotic syndrome as long as they develop the disease within the so-called normal age of nephrotic syndrome, so between 2 and 10 years of age. It's much more important whether they respond to initial prednisone therapy.
Thank you. And regarding age, how do you approach the transition care from pediatric to adult nephrology in patients with relapsing disease or progressive nephrotic syndrome?
Yeah, thank you very much. This is a very, very important question, and I'm not sure whether there is the final solution has already been found. So I think all of us we are here today are eager to establish functioning processes of transfer and also transition. So what we do is that we start the process of transition very early. Also, with the time of diagnosis, we start the process of transition. We have in our center, we have a modular concept of transition with repeated educational courses for patients and parents. And at the time of transfer, we normally do overlapping outpatient appointments with the colleagues from the adult department to be sure that they really know the individual needs of our patients. And it is of utmost importance that adult nephrologists and pediatric nephrologists do speak the same language in terms of understanding the disease and future concepts of therapy.
Thank you so much. And the last question, Professor Lutz. What role do genetic studies, we're back once more to genetic studies, currently played in guidelines for individualizing therapy of nephrotic syndrome?
It's again another very good question. So we already heard about the importance of genetics in the case of steroid resistance. I think we have faced a number of very interesting publications on genetic investigations that might perhaps predict the response to prednisone therapy, for example. But at that point, I do not think that these concepts or ideas are really it's really possible to really translate that already to guideline recommendations. So this is, I think, still a way to go.
Thank you. Thank you kindly, Professor Weber, for your brilliant presentation and for sharing with us your ideas and your achievements. And let me welcome Professor Jürgen Chan, a distinguished expert in pediatric nephrology and immunology, whose work bridges clinical practice and cutting-edge research in glomerular pathologist. His insights into clinical management and long-term care are available into our discussion now. Professor Eugene, you are very welcome.
Thank you so much for your kind invitation. I'm very pleased to be here again this year and meet all of you, as well as meeting my good friends Marina, Lutz, and Jürgen. So it's a good evening now in Hong Kong, but I'm very pleased to talk about the use of anti-CD20 in childhood steroid-resistant nephrotic syndrome. And I'm a pediatric nephrologist in Hong Kong, working in the Chinese University of Hong Kong and Hong Kong Children's Hospital. So a brief overview, as Marina has pointed out, is nephrotic syndrome is broadly divided into steroid-sensitive and steroid-resistant nephrotic syndrome. The diagnosis of steroid-resistant nephrotic syndrome is important because it's at high risk of developing kidney failure, and it can broadly divide into either immune dysregulation or monogenic in terms of pathogenesis. So Marina has mentioned the identification of autoantibodies against nephrin, and it has become an important biomarker or even pathogenic driver in steroid-sensitive nephrotic syndrome. But what is known in steroid-resistant nephrotic syndrome is really, really limited in 2024. At that time, the only article was published from a Japanese cohort, which they identified those patients with non-genetic SLNS that developed post-transplant FSGS recurrence. Almost 100% of them had positive anti-nephrin antibodies. But otherwise, it's like a black box. We do not know much about what is the underlying pathogenesis, or does autoantibodies against nephrin matter in steroid-resistant nephrotic syndrome. And a major finding, I think, in 2025 is published in KI, again from the Hamburg cohort. In this cohort, they tried to look at children with steroid-resistant nephrotic syndrome who are either having genetic or non-genetic form. And as you can see, the non-genetic form has about 18% of them being positive with anti-nephrin antibodies, which is markedly below the proportions of patients that have these antibodies in the steroid-sensitive or dependent nephrotic syndrome. However, still, it is really important because the presence of the antibodies in steroid-resistant nephrotic syndrome actually predicts the response to immunosuppression. Another article from Italy actually showed that apart from the anti-nephrin antibody, there is also other form of anti-sleep antibodies, basically against the glomerular filtration membrane. And Several features was identified. First, it is more common to observe anti-SLEED antibodies in the case of non-genetic SRNS, as well as secondary steroid-resistant nephrotic syndrome, meaning they have a previous response to immunosuppression. And also very important, the identification of such anti-SLEED antibodies also predict a favorable response to immunosuppression. So really coincide with what Marina has mentioned before, the present need of SRNS is really to identify a biomarker that I can identify patients who will benefit from intensification of immunosuppression. So for the current guidelines, I just roughly go through is after 4 to 6 weeks of steroid, if remain one non-responsive, the patient is classified as steroid-resistant nephrotic syndrome and followed by 6 months of calcium inhibitors. And if not responsive, they will be considered as CNI-resistant, steroid-resistant nephrotic syndrome. They can either enroll into a clinical trial, which is not available in a lot of parts of the world, or if it is not possible, then we would consider rituximab. So in the retrospective cohort studies, actually, there has been quite a long duration of data collecting, but most of these data are retrospective in nature and also comprise only a small number of patients. And the rituximab dosing is quite heterogeneous, but in most cases, it's given in 2 to 4 infusions because of the possible loss through the urinary heavy proteinuria. And the range of response in terms of partial and complete remission can range between 1/3 to 2/3. So the only randomized control trial on rituximab was done almost 13 years ago in Genoa. And at that time, it was randomized between 16 and 15 patients against rituximab versus tapering corticosteroid and calcium inhibitor. However, rituximab did not reduce the proteinuria at 3 months in this particular RCT. Nonetheless, I think one of the important problems of this trial is having a very short observation period, because in our clinical experience, the remission usually takes much longer than 3 months. Another important randomized control trial also failed to demonstrate an effect of anti-CD20, and this is with a low dose of ofatumumab against the placebo in the patients who are CNI resistant at 6 months. So we did a large multi-center retrospective cohort study among 28 pediatric nephrology centers in 19 countries. We recruited a total of 246 children with steroid-resistant nephrotic syndrome. The age at diagnosis is about 6.9 years old, and slightly more than half of the patients were male in gender. FSGS still constitute about 60% of cases and MCD in 1/3, and we had a follow-up period of about 3 years after the use of rituximab. So basically, we divided the patients into either CNI resistant, meaning they have received CNI without a response for more than 6 months, or if it was given early, less than 6 months for various reasons. For example, if the patient is suffering a lot from the complications from SRNS. And a majority of patients were given either 2 to 4 infusions of 375 milligram per meter square rituximab. And you can appreciate that in the traditional CNI resistant group, the complete and partial remission is still attained in about 1/3 of patients 6 to 12 months after rituximab. And we did observe a higher rate of remissions in the early treatment group, which I think is because there is a combination effect from both the rituximab and also CNI. And importantly, having a response actually confers a very good long-term kidney survival. If the patient is able to attain a complete remission by 6 months after rituximab, they can almost have 100% kidney survival up to like 10 years. What to do with the patients who do not respond, and we highly suspect they have an immune-mediated cause? I think one of the regimens that has been proposed in the literature is the addition of daratumumab, which is an anti-CD 38 against the plasma cell, which do not demonstrate a CD20 marker on it, and therefore explaining why rituximab is unable to deplete the B cells and leading to a remission of disease. And as you can see here, it still only a small number of patients of 7, but a lot of these patients, after giving this combination effects of regimen, actually see a lowering of proteinuria. Here you can see that there is a significant reduction of proteinuria 3 months after a combination treatment, as well as an increase in the serum albumin level. So this is what are the new therapeutic targets? I use the figure produced by Manula from Rome. And I think it's really good to look at all the different subtypes of the B cells. And one of which that is not being mentioned here is the B cell activating factor, which is the main agent working on is the belimumab, but it doesn't really work in about SDNS, and there is no study in SRNS. And other is a deeper B cell depletion, including those in the tissue, that can be tackled with the use of second-generation obinutuzumab. Again, the current literature only have evidence in FRSDNS, and it is also retrospective in nature, but this is potentially also helpful in SRNS. And finally, is as what I've discussed in targeting long-lived plasma cells that do not demonstrate a CD20 marker on their cell surface, and this can be used in the terms of add-on daratumumab. So once again, thank you so much for the opportunity to share our experience and research in SRNS.
Thank you so much, Professor Jürgen Chan. Very interesting, this last data. And with that, the first question, how do immunological mechanisms inform you therapeutic decisions in complex or atypical cases of nephrotic syndrome?
I think what we know now is just a small subset of patients have the positivity for anti-nephrin antibodies, and that is why it explains in quite a bit of patients, they may not respond that well, even we give the rituximab after the long duration use of CNI. So I think in the future, it's really important to be able to check for these markers quite reliably to identify which patients may respond to these anti-CD20 treatments.
Mm-hmm. And are there promising immunomodulatory agents or biologics that you believe will soon become part of standard care? Because these are the researchers, and what will be the next step? What you mean? What you're thinking about?
I think a deeper B cell depletion with obinutuzumab may potentially work. We just have 1 or 2 cases in terms of clinical experience, but I think in patients who do not respond with rituximab, when we give obinutuzumab, they can also potentially have a disease-depleting remission effect. But I think more research will be required as it is used now in lupus nephritis with quite a good response as an add-on therapy.
Mm-hmm. Thank you very much. And with these biologics, what are the key challenges in integrating precision medicine into routine pediatric nephrology practice?
Again, I think it's important to identify the biomarker that can predict the favorable response to immunosuppression. I think that is what we really need to push forward in the next few years.
Thank you so much, Professor Chan, for your valuable contribution. Your expertise in immunology and your forward-looking approach to therapy are crucial as we explore new horizons in treatment nephrotic syndrome in children. Thank you so much for your participation, for your brilliant presentation. And today I have a privilege of stepping in for Professor Ingreta Bagdasarova from Ukraine, who will celebrate her 19th birthday next year. We send her our warmest wishes for continued health and ongoing contributions in this field and in our country. She is a very, Professor Bagdasarova's legacy in pediatric nephrology is very profound. Under her supervision, a doctoral dissertation of nephrotic syndrome in children was successfully defended. And I had a great honor of studying under the mentorship and working alongside her for 8 years, and expertise that deeply shaped me a clinical and academic path. But I see that Professor Bagdasarova now is not available to present. Let me see. Yes. So, so probably I will present. I will present our results from the name of Professor Bagdasarova. Okay. So, dear colleagues, thank you. I'm honored to present the evidence-based approach to the treatment of nephrotic syndrome in children, focusing on both steroid-sensitive and steroid-resistant forms. This presentation draws from over 800 pediatric cases and clinical legacy of Professor Bagdasarova and myself. This is more than 50 years experience. So let me begin with classification. Professor Bagdasarova proposed a division of nephrotic syndrome into steroid-sensitive nephrotic syndrome with high sensitivity, rapid normalization of urine test within 5-10 days over initiation of steroid therapy, the moderate sensitivity, normalization within up to 4 weeks, and partial sensitivity, positive dynamics in proteinuria, and resolution of edema within 6 weeks. I would like to mention that this classification was proposed 35 years ago. So now for us it's obvious to use this clarification, but what is interesting, what happened was, it was 35 years ago. And steroid-resistant nephrotic syndrome defined by persistent proteinuria after a minimum 4 weeks of full dose of therapy. In clinical practice, approximately 75 of pediatric cases fall under steroid-sensitive nephrotic syndrome. This distribution, what is interesting, is mirrors Mendelian ratios, roughly 3-to-1. 75% to 25% of resistant cases, suggesting a genetic underpinning of the responsible. And initial treatment strategy for the steroid-sensitive nephrotic syndrome involves, as usually for us, is normal corticosteroids at 1.5 to 2 milligrams per kilogram, not exceeding 60 milligrams for 6 weeks during the first episode and up to 8 weeks during the relapse. This is followed by a gradual tapering schedule over the 8-12 months, as per protocols developed by Professor Bagdasarova. Extending the duration of steroid therapy has been shown to significantly reduce relapse rates, and the cumulative dose with small, and it's look like equivalent as we used 40 milligrams each other day for 4 or 6 months. We primarily used prednisolone or methylprednisolone, which proved most effective in experience Professor Bagdasarova. In my own practice, I use deflazacort, which has shown promise with fewer side effects. It's available in Italy and Germany. Tapering protocol. Tapering begins with a reduction of 2.5 milligrams daily, continuing until the dose reaches 17.5 or 12.5 milligrams per day, which depends on body mass of patient. At that point, therapy shifts to intermittent dosing, 3 days per week. So 3 days take prednisolone, 4 days without prednisolone. Every 8 weeks, the dose is reduced by another 2.5 milligrams, and this schedule typically concludes within 12 months and has demonstrated fewer side effects compared with alternative regimens. Adjunct the therapies in relapse. Chloroquine reduces the relapse up to 20-25%. Either chlorambucil up to 80% reduction when combined with steroids, or methylmecophenolate reduced relapse rate or risk for 60–70%, or rituximab, which we used widely the last 2 years. Many thanks once more for Professor Lutz, who helped us to make this trial, and we administered it over 2–3 years, associated with long-term remission without any relapses if we use the rituximab every 6 or 8–9 months. Agents such as levomazole are avoided due to limited efficacy in our practice, while cyclophosphamide and cyclosporin A carry higher toxicity risks. And frequent relapses and steroid dependence. Approximately 60% of initially steroid-sensitive children eventually develop steroid dependency, defined as 2 or more relapses. And in such cases, 3 days per week low-dose steroids can reduce relapse rates up to 60%. Steroid-sparing agents. When maintenance therapy fails, first-line steroid-sparing agents such as chlorambucil or methylmecophenolate are recommended in our country. If ineffective, calcineurin inhibitors, and usually we try to use tacrolimus or rituximab as second-line options. And we carefully monitoring for growth suppression, for hypertension and bone demineralization. It's very important, you know. If non-response to steroids, the initial steps, the steroid resistance is diagnosed when proteinuria persists after 4 weeks of full-dose steroid therapy. However, Professor Bagdasarov recommends extended steroid therapy to 6 weeks before confirming resistance, resistance. Initial management should include, from our point of view, kidney biopsy, most commonly focal segmental glomerulosclerosis or membranous nephropathy, genetic testing. It's not available now in Ukraine, but we try to do it. And evaluation for secondary causes such as infections or drugs exposures, and what treatment approaches should be used in our country in particular. First-line treatment, the calcineurin inhibitors, cyclosporin, or widely we use tacrolimus, but Professor Bagdasarov recommends, and we usually use it in our practice for minimum 24 months. Then usually used IC inhibitors or blockers with any rate of proteinuria, and renal function and potassium levels must be closely monitored. It's obvious. So the complete remission with negative or trace proteinuria on rituximab or with tacrolimus, or even we usually combine tacrolimus with rituximab, it could be nearly in 45–60% of our patients. So we would like to confirm that this therapy could be used in steroid-resistant patients. And as a future directions, we think that genetic and biomarker-guided therapy need to be used, should to be used, precision medicine approaches, new biologics. That's why we have the questions to our speakers, and safer long-term regimens with reduced toxicity. So in summary, we think that early classification of steroid sensitivity, protocol-driven steroid use, timely addition of immunosuppressives, and integration of modern biologics. And In summary, we have some questions. Let me give the answer. What is the ratio of the dose of deflazacort and prednisolone? One tablet of prednisolone corresponds to 6 milligrams of deflazacort and 4 milligrams of metipred. And the maximum dosage of deflazacort does not exceed 60 milligrams. And what drug besides rituximab do you use in the treatment of steroid-resistant nephrotic syndrome? Usually, after discontinuing steroids, we prescribe tacrolimus for 1 year and rituximab in parallel with tacrolimus, which is administered 2 injections per year, and the third injection could be a half of dosage, and after 6 or 8 months under the control of CD and IgG. So this is the experience from our part, from Ukraine. And dear colleagues, now we move into roundtable phase of our session, and with time limited, I would like to propose some questions for you, and I will be grateful if you kindly give the answer for this. The first one: what are the key barriers you face when implementing nephrotic syndrome treatment protocols within your healthcare system, and how have you addressed them? Because there are different healthcare systems, and these protocols are universal, and with our last presentation we shows our possibilities. So please, what are you thinking about implementing these protocols in your countries? Yes, please, Marina Vivarelli.
So I wanted to make an important observation. I think it's really important to use the IPNA guidelines or the KDIGO guidelines. The regimen for glucocorticoids has a strong basis in a lot of evidence, and it has gone in the direction of reducing the glucocorticoid toxicity and the total cumulative dose. So it is wrong in 2025 to give a year of glucocorticoids for nephrotic syndrome. It should not be done. It is toxic, and it absolutely is not evidence-based. So in whatever part of the world, you need to follow the IPNA guidelines. And this is super, super important. The glucocorticoids, it can be deflazacort if you prefer compared to methylprednisolone or prednisone. Better to use the equivalent doses, and that's fine. But the cumulative dose needs to be as low as possible. There is absolutely no evidence giving more is better. And this is absolutely crucial. The other concept is when to repeat rituximab. We have no evidence to repeat rituximab based on total B cell levels, and have to be careful. So I really, really would recommend the implementation in every part of the world of the IPNA guidelines in terms of how to use these agents.
Thank you so much. We are to follow these guidelines. These guidelines is crucial for the treatment of nephrotic syndrome, and we try to adopt it, for example, for our possibilities in Ukraine. And dear Jürgen, your opinion, please, regarding the implementing the protocols within your healthcare system, please.
Yes, in Hong Kong, we have a public healthcare system, and all patients, they have almost free access to medical care. But what I think is important as a pediatric nephrologist is also about education. So I would interpret that a lot of pediatric nephrologists will be reading the latest guideline issue from KDIGO and also from IPNA. But it is also true that nephrotic syndrome is such a common disease that it can be managed by primary care doctor or sometimes by relative general pediatrician without much experience in pediatric nephrology. So what we did is we do a lot of educational symposium and series for our general pediatricians and or those in training, as well as primary care doctors. And we also produce a clinical referral workflow to make sure these patients are timely referred to experienced pediatric nephrologists so we can manage these patients with great outcomes. I think this is also one part that KDIGO and ITNA will not be able to achieve without the support in regional and also national nephrology societies.
Thank you, Professor Jürgen Chan. And please, Professor Lutz Weber.
Yeah, thank you very much. First of all, I would like to point out that I absolutely agree to Marina's opinion on the IPNA guideline. I really think we should stick to that worldwide. That is why we in Germany are currently updating our national guideline and adapting that to the definitions given in the IPNA guideline. This is very, very important, not at least to make sure that future clinical trials can be really spread out to everywhere, not only to single countries. I think this is very important. And another point is for me that in case of spreading out new therapeutic regimen and ideas, it's very important to really listen to the patient voices. So when we do that for the patients, the most important threat in nephrotic syndrome is the relapsing character of the disease and the fear of treatment-associated side effects. So it is important to, as Marina and Eugene already pointed out, to find therapeutic strategies that really reduce the burden of side effects and to find regimes that are applicable to patients. And for that, I absolutely agree with Eugene. We have to define in our national communities when pediatric nephrology specialist is necessary in treating the disease and to what stage a general practitioner could take care for the patient. I think this is of great importance.
Absolutely supporting your point of view, I would like to propose the last question for our roundtable. What long-term strategies have proven most effective in ensuring treatment adherence among pediatric patients and their families? Probably, Professor Lutz, you will continue with this question.
Yeah, I will try to, because but I have to admit that I have not found the final solution to that yet. So I think it's a mixture of what has already been said. So it is important to really educate patients and to bring the disease to their attention in a way that they can really understand it. So it is important to teach them in monitoring the disease, because this is basically done at home. So they should really be able to decide when to really look for help from the doctor. And for me, crucial is the urinalysis, and all families with kids with nephrotic syndrome should be really well trained in doing urinalysis and interpreting this. And as far as the medication is concerned, well, in my experience, it has always been a good choice to be open and really frank with the patients. So really tell them what the medication can do, what it can, and what could be the potential side effects. Because after all, what is important in a disease like this, which probably accompanies the patient for years, is really trust in the treating physician. So never risk that in treating your patient.
I totally agree with you. Thank you. And Professor Jürgen Chan, your opinion?
This is probably one of the most challenging parts in managing pediatric patients as they grow into adulthood. We have two strategies in our department, one of which is very comprehensive transition program that we started quite early into the adolescence, about 13 or 14 years old. We first did it with the kidney failure patients, and then we progressed it to CKD patients, and now even the GN patients are involved. And it involved a multidisciplinary approach, not only with doctors, but also more importantly, the nurses, the psychologists, occupational therapies, and so on. It's not only about the medicine, but it's overall the perception and understanding of the disease. I think this is hugely important, and I encourage that if you have that resources to gradually develop a transition program that can fit in your own resource. And the other, I think, is talking to the patients, because sometimes we ask how you can take the medicine better. The patients sometimes give you unexpected result. For example, the girls will tell you, I always have to take off my cosmetic. So maybe best to put the medicine in the toilet because I need to take off my cosmetic every night. So I think feeding into the lifestyle of the patients and is most important. As you know, like MMF, sometimes they advise you to avoid food, even it's not as important as tacrolimus. And I find this an important reason why the patients going to school, they forget to take the MMF. So I think we need to work very closely with the family, how the parents can help and how the children themselves can take care of themselves.
Thank you so much. And please, Professor Marina Vivarelli, we would like to ask him for your closing remarks of this roundtable. And please be closer to the microphone, please, okay?
There, you can probably hear me better now. Sorry, I had forgotten to put it down. My closing remarks are that, it's always so interesting to look at how nephrotic syndrome is dealt with in different parts of the world. And we always learn so much from seeing how things are done in different parts of the world. And it's really important to maintain the perspective that irrespective of where we are, there are certain things that should be done in a certain way. And then there are other things in which we really don't have the evidence yet. And there is no right or wrong answer. And we have to work together to try to gain as much evidence as possible to be able to then use reasonable answers based on evidence published of high quality. So I really think it's important, and it's important that that evidence is derived from all different parts of the world because, children can be different in different parts of the world. And sometimes even from the most difficult situations, you can really derive high quality evidence. So it's been a real pleasure, and thank you so much for having me.
Thank you so much. And as we approach to the end of our session, I would like to thank each of you once more again for your contributions, insights, and dedication to improving outcomes for children with nephrotic syndrome. Professor Jürgen Floege, Professor Marina Vivarelli, Professor Lutz, Professor Eugene Chan, and Professor Bagdasarova. And may I kindly ask Professor Jürgen to make the closing remarks, please.
Well, thank you. It's been a pleasure. As usual, I have learned something, so it's very good to listen to people who you don't listen to every day. And I hope that you had the same good experience, and I wish you all the best luck for whatever is to come.
Thank you. This roundtable has been a rare opportunity to hear directly from the minds behind the guidelines and to engage in mindful dialogue with global leaders, with you in pediatric nephrology. We look forward to continue this collaboration and to the future Arena Nexus sections and bring together science, practice, and innovation. Thank you and have a wonderful, joyful day. Thank you so much, colleagues.